So now let's get started with today's clinical topic. And our speaker today is Dr. Timothy Kosinski. He's a highly sought after speaker and teacher in the world of implant dentistry. He's taught hundreds of courses and written dozens of articles. But even more important, he is the guy. He is a mentor to so many dentists as they successfully add implant dentistry to their practice. He's also the editor of General Dentistry, which is the official journal of the AGD. He's done so much for AGD, which is a fabulous organization. He's got another great lecture for us today, so I'm just going to turn it over to my friend, Dr. Tim Kosinski, to present grafting and suturing tips for success. Hey, Tim, it's all yours.
Dr. Park, congratulations on our end. I'm in a hotel room in Manhattan right now. So it's a little bit different, not in my office, but welcome everybody. And I'm always honored for the team at Glidewell to allow me to share some of my experiences with a big audience today. And one of the most popular things that we do, and I'm not sure why, is suturing. And so we're going to talk about some of the suturing techniques that I use every day in my practice. As you all know, we place a lot of implants and we restore a lot of implants, but even more important than placing this little spark plug in the jaw, which I don't think is the hardest thing that we do, it's really setting the foundation so that we can create proper aesthetics and functions for our patients. Smile design, emergence profile are all very, very important parts of implant dentistry. But before we can do that, we have to take a step backwards and we have to prepare the site. So grafting is a very, very important part of what we do every day in our practices, building the bone. To me, bone is gold. It's just the most important thing. And the more bone we have, the better the result will be, and the better the prognosis and the outcome. So we have to know what materials to use. And to go along with that, as we're setting the foundation, suturing is such a critical part of our success today. So enough said about that. Just a view of beautiful Lake Michigan up in northern Michigan. If you haven't visited, it's just a beautiful place to be. And we'll just move forward. So our learning objectives today, really simple. We're going to talk about different types of sutures that I use or the techniques that are used, needles and other usages. Very, very briefly, we don't need to inventory a million things in our practice. For those of you who heard me before, you know, I'm just a general dentist in Detroit, nothing special. And we were talking about innovations and investing, but we don't need to buy everything that's on the market with our reps coming in and saying, this is better and this is better. We go to meetings and we have a tendency to purchase a lot. I'm going to keep things really simple. I use 2 different kinds of sutures, and I use 3 different kinds of grafting materials, and I use 1 membrane, and all are available through Glidewell or Newport Biologics. Keep it simple. There's 1,000 ways, doctors, for you to do what I'm doing. I'm not going to show you 1,000 ways. I'm going to show you what makes me successful in my practice in the suburbs of Detroit. We're going to talk about different types of knots, different types of sutures very briefly. We're going to talk about how we can predictably suture and anticipate proper healing. When we're grafting, I like to say in my lectures that I can teach you how to grow bone 100% of the time. Now, that's a very bold statement from this guy in Detroit. We're talking about sockets with all walls intact, and we're talking about when the facial plate is missing. Those are the two applications that we want to discuss, that we can show you how to grow bone 100% of the time and really maximize the successes in your practice and with your dental implants. Flap or reflection, critical part of dentistry today. We're going to show you my techniques. I like to call it an envelope reflection. So I'm not making vertical incisions into mucosa. That's how we were trained. I just did a meeting at the California Dental Association and had everybody raise their hands. Most of us learn to reflect tissue or to flap tissue by making a crestal incision and making vertical incisions, different places, 1 tooth over, interproximal tissue saving techniques. But what I want you what I want to demonstrate is we're not making vertical incisions into mucosa. Why? If we incise into mucosa, we will get histamine and prostaglandin release, and the patients will hurt, period. Our patients don't hurt. We are filleting patients from ramus to ramus, from tuberosity to tuberosity. As long as you're not incising into mucosa, our patients do not experience a lot of discomfort. They don't really bruise that often. And we can minimize the amount of analgesics that we need for our patients. It is very rare for me to prescribe a narcotic, even with all the invasive procedures we're doing. So we're going to demonstrate that. And we're going to talk about a little bit about extractions and obviously grafting in preparation for dental implants, as we mentioned. So, I'm a big user of the Hahn implant system. I think Jack Hahn is brilliant. I think this is a product that makes me very efficient, effective, and very profitable. To me, it is a very high-end material, high-end product, which allows me to have tremendous support by the Glidewell team, especially the dental implant team at Glidewell. I feel that they are second to none. Being from Detroit, I love that this is US made. My patients really appreciate that this is a product made here, right here in California. So, placing an implant is not the hardest thing, but we have to prepare the site. We'll talk about that a little bit. This is not really an implant training program. We've done that before, but more of a tissue management, building bone, and suturing product. You can see in the upper right-hand screen my reflection. And I refer to this as an envelope, like a number 10 envelope. You lift the flap, you blow into it. I'm not making vertical incisions, and I can't focus on that enough. I'm not making vertical incisions into mucosa. You can see here that I did not elevate the palatal tissue here. I need to see the facial plate of bone. I've done over 17,000 implants, and I'm going to tell you right here, my failures, my problems is because I placed my implants too far facial. How did I do that? Well, we did a lot of flapless procedures, a lot of punches. We used our surgical guides to kind of maximize the position, but oftentimes we missed. If the implant is too far facial, we don't have 1 millimeter or 2 millimeter of facial plate of bone, that's where we run into issues. So placing the implant by reflecting the tissue allows me to see the implant position, allows me to see the amount of facial plate of bone that I have there, and it maximizes my end result. If I was missing a facial plate, I'm going to show you how we can repair that. Suturing is very important. So here I did a mattress suture. I'm going to demonstrate all these in a little bit more detail. But what the most important part of what I'm showing you right here is the lower right photograph. Very, very important. It's critical in all our implant placements that we have a band of attached gingiva on the facial aspect of every implant. We must have at least 2 millimeters of attached gingiva on the facial aspect of our implants. So I want you to think about that from now on, from this point on, regardless of your experience level, that we must maintain attached gingiva. Now, how do we do that? We know when we lose teeth, bone shrinks up and in the upper jaw, down and in the lower jaw, and it can affect the amount of attached gingiva we have on the facial aspect of our dental implants. So it's important that you realize this. So suturing is very important. Now look at the upper right slide. I know I'm going kind of quick here, and we can go into greater details through some of our publications and what we're doing. Most of us, excuse me one second, most of us suture from facial to palatal. That's how we were trained, facial to palatal. But if we are using a membrane of some sort, if we go facial to palatal with our reverse cutting needle, oftentimes we will inadvertently engage that membrane. Patient comes back at some point and we remove the sutures and we remove that membrane. Now, if we are grafting a surgical site, we must protect the graft from invagination of epithelium for at least 6 weeks. That's a very important number, at least 6 weeks. So I have one membrane, a resorbable membrane that will last much longer than 6 weeks. How do we ensure that we don't remove that membrane upon suture removal? Well, my technique is to take my reverse cutting needle, 3/8 or half circle, and I go from crestal to facial. This allows my reverse cutting needle to slide over the top of any membrane that I may have in position. So from crestal to facial, then I will reverse the needle and go from crestal to palatal in this situation, or to lingual. I have a healing abutment here. We placed our implant, which means that I got good torque, at least 25 Newton centimeters of initial torque, and I was able to place a healing abutment. Now I'm suturing simple 2 interrupted sutures around that healing abutment. And I'm very, very carefully evaluating the band of attached gingiva on the facial aspect of the implant. Again, we're not going to talk about surgical placement of the implant and those rules. We can do that for another time. But it's important that when we made our envelope reflection, not making vertical incisions, the reflection will go right back into place. It allows me to have complete control of the situation. So there's a lot of different sutures out there, doctors, and you may have your favorites. I know every dentist has their favorites. I personally use my PGA polyglycolic acid synthetic absorbable. I purchased these from Newport Biologics. It's a braided material. It resorbs in about 28 days, but it resorbs or absorbs to water. So I do not get a lot of inflammation when I'm using a polyglycolic acid synthetic suture material. That is my favorite. It feels like silk, but I don't use silk in my office because it really absorbs bacteria. Plain gut, chromic gut, if you're used to it, it's inexpensive, but I find it difficult to handle. So I have my favorite. I use the PGA material that's colored violet. It's a violet color. So my staff really appreciates because we can see it very clearly. So I have basically one type of suture material in my practice. I have 2 thread size, a 3/0 and a 4/0 in my practice. And I have 2 needle sizes, depending on the situation or circumstances that I have to deal with, a 3/8 circle and a 1/2 circle. So basically, I have one type of material and I have 4 different sutures. That's all I have in my office. I don't need anything else. I don't need to inventory a lot of different products. I think you're better off investing in some of the new technology that's available there than a myriad of materials that you're never using in your practice. And we all have those. This is a great suture book, and I do recommend it if you want to take a snapshot of it. It's schematics of the different types of suturing. It allows you to practice at home on an orange or an egg, not an egg, but a lime or a lemon. It allows you to become really proficient in suturing. And suturing is a very, very important part of getting a better prognosis in your implant cases. So let's just go through a couple very simple procedures. I think you understand interrupted sutures. Most of us understand it. This diagram shows we're going from facial to crest. I strongly recommend that you go from crest to facial, then reverse the needle, excuse me, and go from crest to lingual in this situation. But basically, you are going through the tissue in the front and the back of the area, and then you're tying a knot. How do I tie my knots? I go 2 forward, tie it down. Then I will go 2 forward again, and that second 2 forward will pull that knot down to the position that you want. I will then go 1 reverse, and that will tie the knot where your knots will not come loose in your practice. And that's very, very important. Continuous suture, I'll try to demonstrate that here too. Also, is a very, very efficient suture. I know my staff loves it. Patients will ask, well, how many sutures did you put in? 1. And it could be from 1 inch to basically a half an arch in certain situations. So what I'm doing here is making my first interrupted knot from facial to lingual or palatal here. and I'm tying a knot, and then I'm simply repeating that motion. But rather than tying a knot individually, which takes a lot of time, I will tie the knot through the rabbit ears that we create. So we're going through the tissue, and we're simply continually making our penetration from facial to lingual here. And at the end, that's when we will go two forward, tie the knot, two forward, set that knot, and one backwards to eliminate any kind of opening. Now, when we're doing a continuous suture, depending on the circumstances, I do probably recommend that you put a couple interrupted in there, because it really is just one suture. And if it does come loose, the whole thing will unravel. So as a safety net, I will normally put a couple interrupted, one on each end, just to make sure that that continuous suture stays in place. So let's look at a case. That's what you're here for. So interesting case. I want you to look at closely the mucogingival line. Do we have a band of attached gingiva in this situation? Here we're making an incision, a crestal incision, and we're placing a dental implant. This happened to be a guided surgery. It was a thin ridge, but we were able to place the implant where there was available hard tissue. So the implant is placed into the jawbone. We're placing it level with the apices of the adjacent teeth. It makes it a very safe procedure. We brought up CBCT investing. I think it's a very, very important tool in implant dentistry today. It allows us to not only virtually place our implants, but actually virtually design our final prostheses if we so choose. So this was a guided surgery. So here I did a continuous suture. Okay, so the tissue is, the implant was placed, we made a crestal incision, the tissue was replaced and allowed to heal. I removed the sutures in a week, and here's 2 weeks post-op. Tissue heals beautifully. Doctors, critically look at the mucogingival line. We must have attached gingiva on the facial aspect of our implants. When bone is lost, when teeth are lost, bone will shrink down and in, and it will pull the mucosa towards the lingual in this situation. So now patient healed 3 months, and I'm going to uncover the implant. We're going to expose the implant. So here I did my tissue punch. Many of us use a tissue punch. I may use a laser. Very important slide here. What am I cutting into with this tissue punch to find that implant, to uncover that implant? Cutting into mucosa. I made a mistake, didn't I? I don't have a band of attached gingiva on the facial aspect of my implant. That's significant, doctors. We did an analog impression. I took the impression anyways. We take a radiograph, any metal-to-metal components. We took a impression. So I knew I made a mistake. So I need to reposition that attached gingiva onto the facial aspect of that implant. How do I do that? Well, I'm going to make another incision. I'm going to incise slightly lingual to the crest. So I want to harvest that band of attached gingiva. Remember, I said I need at least 2 millimeters. I want to harvest that band of attached gingiva that's on the slightly lingual portion of the crest. Here I'm using an Orban knife to go around the tooth. I'm again making my envelope reflection, not incising into mucosa if I can help it. And I'm reflecting it, peeling it like an orange. Very important slide here, doctors. I'm reflecting that tissue, and I've taken that band of attached gingiva that was on the crest, and I moved it to the facial aspect of my implant. I did not reflect the lingual tissue. I did not reflect the lingual tissue. It is still intact. It is still intact. I can then, because this implant has integrated, I'm putting a tall healing abutment. This is the Han implant healing abutment. It's 5 millimeters tall. and it's penetrating through the soft tissue. I'm going to torque that healing abutment to 25 Newton centimeters so that it does not come loose. This is an important slide. I am going to now suture that band of attached gingiva that used to be on the crest. I'm going to suture it to the facial aspect of my implants, to the facial aspect of my healing abutment that's penetrating through the soft tissue. So to do that, I've taken my reverse cutting needle, 3/8 circle, 3/0 thread width, and I went from, in this situation, I went from facial through that facial reflection. I am not engaging the lingual tissue. I am not engaging the lingual tissue. I'm then taking that suture and I'm wrapping it around that healing abutment, not engaging the lingual tissue, wrapping it around that healing abutment. Now, your staff may have to hold it down in some situations. Then I'm taking my needle and reversing it and going from distal facial, not engaging the lingual tissue, coming around the healing abutment, not engaging the lingual tissue, and tying my knot. Two forward, one back. One suture. I've taken that band of attached gingiva that used to be on the crest, and I've moved it to the facial aspect of my healing abutment. You can see where I did the tissue punch in the mucosa. I'm not concerned. I'm not concerned that the crestal bone is exposed. Physiologically, epithelium is going to grow 0.5 millimeter to 1 millimeter a day, no matter what. It's physiologic. It's not a painful procedure. Advil if you need, warm salt water. I don't cover it. I don't put anything on it. I don't super glue it. It will heal in a very short amount of time. And you can see that crestal plate is exposed. One suture, periodontal suture, a sling suture around that tooth, around the healing abutment. Doctors, look at this. 3 weeks post-op. And this is routine. We expect this. So from this juncture on, I want you, regardless how experienced you are in implant placement, I want you to respect the band of attached gingiva and really understand that. We take the healing abutment out and we created a band of attached gingiva on the facial aspect. We have a tissue cuff. This is a healthy situation. And the team at Glidewell was able to fabricate a zirconia crown. We torque it at 35 Newton centimeters, and we create form and function for our patient and really improve the quality of their life dramatically. And we're able to provide quite a service. We are all capable of doing it, but it's important that you realize how important this reflection and suture is. You know, if we mentioned this already, if we lose teeth, bone will shrink down and in, the ridge height is harmed, is damaged. Many of us don't place implants because we're concerned about two anatomical problems. Posterior mandible, we're concerned about the position of the mandibular nerve. We're concerned about, in the posterior maxilla, we're concerned about the sinus. Grafting is critical at the time of extraction. It'll help minimize bone loss, supports the soft tissue, helps prevent periodontal pathology, and we can provide adequate site for dental implants in a very short 3 to 4 months. It's important. Without grafting, you know that soft tissue will grow into the socket site. We will get horizontal and vertical bone loss. The literature will say up to 30 to 60%. If you want to take one photograph or a second photograph, except for that suture book, take this one, because this is how you educate and communicate to your patients why grafting is important. If you take a tooth out and you do not graft that site, the chances are we are going to lose 30 to 60% of height or width over a short amount of time. This may indicate that we are not able to place an implant in the future without a much more invasive, expensive surgical protocol. So this is communicating with your patients on why this is important. Why do socket grafts fail? And many of us have done grafting. You understand this. You've taken courses, but you've gone back. You thought you were doing the right thing. And you come back and it's mush. It doesn't heal. Well, the graft has to be protected from invagination of epithelium. So you must use a high quality membrane. I strongly recommend the one membrane I use in my practice, the 3 to 4 month resorbable membrane from Newport Biologic, very high quality. And any kind of an infection. So when we take a tooth out, you have to, this is not an extraction course, but when we take a tooth out, we must curette, you must remove granulation, you remove the snot from the area. Purple blood is bad, red blood is good. We have to understand the principles. Again, membranes, I use a resorbable membrane from Newport Biologics, but you know what? There's tons of grafting material. I'm going to show you 3. That's what I use. That's all I have in my practice. I use an allograft from Newport Biologics, 250 to 1,000 microns. It's different particulate shape. I will use a calcium apatite material through Glidewell again. It's called osteogen material. And I will use a calcium carbonate material again from Newport Biologics in certain situations. Resorbable membranes, I use the 3 to 4 month. It's purified intact collagen from porcine peritoneum. It's very easy for me to manipulate. It is my material of choice. My grafting material is a blend of cortical and cancellous particulate. It is osteoconductive. We can make it osteoinductive by using PRFs or PRPs. Again, a whole nother lecture we can do in the future on how we handle our material. But oftentimes I will just wet it with sterile water or sterile saline. Doctors never use anesthetic to wet your allograft. Anesthetic is pH 2. It will inhibit bone turnover. So be very conscious of that. Do not use anesthetic to wet your allograft materials. I will use a carbonate apatite material, again, from Newport Biologics. It's like a putty material. It is a synthetic material. And I will use a resorbable collagen plug, again, from Newport Biologics. This is not a graft material, though. This is simply a plug, and it's a collagen plug, but it's a high-quality collagen plug that lasts 30 days. I'm going to make a concentric circle in my discussion. Epithelium grows 0.5 millimeter to 1 millimeter a day. We must protect the graft material from invagination of epithelium. That's critical. So we have to protect it. Usually a site will heal in a week to 2 weeks, depending on how large the socket site is. I don't care about primary closure, but I want to protect that site. What about smokers? What if we place an implant immediately in a site and it's exposed? Well, I will use a collagen plug, which is very inexpensive, and I will place it, suture over the top of it to try to protect my implant from tar, nicotine, heat created from our smokers. And then I mentioned osteogen plug, which is one of my favorites. Many of you probably heard me speak on it. It's a calcium carbonate bioactive material made of the same bone building blocks as our natural bone. We don't need a membrane with this material because the material is concentrated such that epithelium has 2 choices. It could try to grow into it, or it will follow the path of least resistance and grow over the top. This is different than an allograft, which always must have a membrane protecting it, just because of the particulate size and shape. Let's go into some clinical cases for the next 10 minutes or so. We have a tooth that's deemed non-restorable. Root canal treated tooth, post. Oftentimes, we probably do more implants on teeth that have post than anything else, especially in the age of COVID. We see so many fractures, but it's a tooth that we're going to remove. We find that it's non-restorable. We are going to remove it. I'm not going to go through my removal technique. This happens to be a physics forceps, which I love. You can investigate that on your own, but we're removing a tooth as atraumatically as possible to the patient. What does atraumatically mean? Well, bone is gold to me. I'd like to keep that facial plate intact if possible, but physiologically, the disease process may have eliminated that facial plate. If all four walls are intact, doctors, all four walls are intact, I love using the osteogen plug, the calcium apatite material in a bovine Achilles tendon matrix. It is not a collagen plug. It has kind of firmness to it, and I will slowly place it into my socket. The blood will absorb into it, and I will place it firmly, not crushing it, but firmly into the socket to the crest of the ridge or slightly above the crest of the ridge. And I will simply place 2 interrupted sutures to hold it in place. Epithelium, again, is going to grow a 0.5 millimeter to 1 millimeter a day, depending on the physiologic properties of the patient, the health of the patient, but it may take a week to 10 days for this to close over. Immediately upon extracting and placing the graft, you can see the radiograph is still radiolucent to some extent. But what happens in 4 months? Doctors, you can actually objectively determine bone turnover through your radiographs and determine at what point do you want to place an implant in this site. Now, again, physiologically, the way we get integration of this graft to natural bone, we are going to get faster healing at the apex and slowly towards the crest. So I expect more radio opacity at the apical portion than at the crest. But I don't care. After 3 or 4 months, depending on the situation, I'm going to place the implant and allow it to heal for another 3 to 4 months anyways. And that bone turnover is going to continue over the next year. I'm able to place my implant in that very, very significant defect. We allow it to heal, and the team at Glidewell here fabricated a custom titanium abutment, and we created emergence profile for our patients, giving them form and function with a dental implant restoration. This is very predictable and effective way of incorporating dental implants into your practice. Interesting case, huge defect. We're going to remove the tooth, and you can see the tremendous amount of damage that was created by the infection. If you look at this defect carefully, you can actually see the Schneiderian membrane. The Schneiderian membrane was not torn, it's there. So in this situation, this may scare a lot of us, certainly something that we're able to manage. I'm going to take a osteogen plug, our calcium apatite material, and I'm very carefully, gingerly placing it into that defect where into the sinus area where the Schneiderian membrane is apparent. Carefully push that material. Now I still have a tremendous defect here. And here I'm going to take my Newport Biologic allograft, 250 to 1,000 microns, because this is a huge defect. And I'm going to make an entirely new facial plate. Doctors, what do we have to do now? We must protect this allograft from invagination of epithelium. So we must protect it and place a membrane, a long-term membrane. How long do I need this membrane to remain intact? At least 6 weeks. I'm using a 3 to 4 month resorbable membrane in my practice. I'm passively placing it. This membrane must be placed at least 2 millimeters beyond any defect. This membrane must be placed at least 2 millimeters beyond any defect, and it must be passively placed. It must remain intact in that site. We're going to passively place it beyond the defect and passively place it onto the palatal aspect of the hard tissue. And again, going back to my suture protocol, when I have a membrane, I'm taking my reverse cutting needle going from crest to facial, crest to palatal. And here I did, you can do interrupted sutures, you can do a continuous suture that we demonstrated, but I want you to look carefully at the band of attached gingiva on the facial aspect of the site. Now, if you go mesially, it looks like we may have a little problem there. We can address that. Immediately, a CBCT analysis immediately following the graft procedure. You can see that we filled that sinus and we created a site, assuming that we are going to get bone turnover in a very short amount of time. This is what it looks like 1 week. I love to see my patients in a week. If I'm filleting them or incising them, I like to follow up with my patients because everybody's a little different. Everybody has different health concerns that we have to deal with. I will remove the sutures, and I don't care that there isn't complete closure there because, again, epithelium is going to grow a 0.5 millimeter to 1 millimeter a day. 4 months post-op, we are going to see a turnover, a change in that site. And a CBCT analysis shows that even though we don't have complete bone turnover, our integration occurred more at the apex than at the crest. Why is that important? Our initial stability with our dental implants is at the apical 2 millimeters. So I will get initial stability with my implant at the apical 2 millimeters, and using the innovative Han implant, which has very aggressive threads, I'm going to allow these implants to integrate for another 4 months, which that integration of hard tissue is going to continue towards the crestal aspect. So I'm evaluating the band of attached gingiva. I'm making my envelope reflection, not incising into mucosal tissue. Doctors, what do we have here? We have bone. And this is something every one of you listening, the 700 or so people listening today, are going to be able to do in your practices as long as you follow a specific recipe. Use high quality materials, wait the proper amount of time. I know we all want to do things fast. I've been doing this too long. Fast is not necessarily better. And evaluate the site, respect the soft tissue. And here I'm just simply going through the implant process. We're going to finish up here in a few minutes, making my osteotomy, small drill, wider drill, making my osteotomy, widening the osteotomy, placing my Han dental implant to the crest, placing my second Han implant to the crest. This is an important slide. The Han implant drill system is very precise, and it will harvest bone. This is autogenous bone or bone that's turning over. You can use this to repair any small defects on the facial or lingual or fill gaps. Autogenous bone, you don't need a membrane to protect it because it's physiologic again. Here I'm placing my second Han implant to the crest. I'm going to put cover screws, bury it, allow it to heal for a period of time, and my post-operative CBCT shows the position of the implant in a grafted site. Again, in suturing, very important here, we're going to do a continuous suture, again, respecting that band of attached gingiva on the facial aspect of my implant. So here I go forward twice, tie it, forward twice again, it'll set that knot, and then one backwards will eliminate that suture from coming loose. I will then go from facial to crestal again, come through the rabbit ears, and tie a continuous suture through the rabbit ears, tying that reflection. And because we didn't make vertical incisions, everything goes back to place perfectly. And then when we get to the end, we have the rabbit ears, two forward, the rabbit ears, my new tail, tie the knot, and we have respected the band of attached gingiva, and we will allow it to heal. I'm going to stop here, Neil. I think you wanted me to stop right at 1 o'clock my time or New York time. And if we have any questions, we can answer them.
We don't have a lot of questions because you were so crystal clear. What a great lecture. I mean, you just have a great way of communicating these issues. And there's so many important things here. I mean, just your emphasis on avoiding vertical releasing incisions is such a valuable point for people to make as far as to get pain-free healing for our patients, and your emphasis on maintaining some attached tissue and then creating some attached tissue if it isn't there. So that's the first question that that I wanted to relay to you. So there's a question here: if there isn't enough keratinized gingiva to begin with, a lot of people recommend using the acellular dermis grafting material. Can you give some thoughts on the use of that material? When is that a good idea?
I'm not a periodontist. Okay. Now the one case that I showed, Neil, we placed the implant, we buried it, and then we evaluated the mucogingival line. And normally, in most situations, I can harvest from the patient's mouth. I just need a band of 2 millimeters. Now, think of a perio probe, doctors. That's not a lot. And if I can just move that tissue to the facial aspect, I'm fine with it. But I also showed you that that crustal bone was exposed. I'm not concerned because physiologically, we're going to get epithelium attach growth of a 0.5 millimeter to 1 millimeter a day. It's just routine. It's the body's healing. If you feel comfortable or needing to use a dermis, that would normally be where we have a lot of bone loss in the edentulous mandible, where it's severe, where there really isn't very much attached gingiva there. Certainly that is an application. I didn't really address that here today, but certainly an option for our doctors.
Yeah, and that kind of goes to another question that we've got here, which is about primary closure, and the question is, if you're not doing a vertical releasing incision, how do you get primary closure? And you're saying that's not a requirement, is to have primary closure. That sometimes
I don't care about primary closure whatsoever because I'm using a high quality material. Neil, you and I have been doing this a long time, and we used a lot of materials over the years. We use Gore-Tex materials. With that material, it was a non-resorbable material. We had to get primary closure. It doesn't exist anymore. We don't use it in dentistry because it was ineffective. Now we're using this high quality stuff that's lasting 3 to 4 months. I need it to last 6 weeks. That's all. And the epithelium will grow over the top of it. I guess if you're using an allograft, passively place a membrane, high quality membrane, but it has to be placed at least 2 millimeters beyond the defect. So you have to feel comfortable reflecting the tissue and being in control. You can reflect all the way to the base of the eye and you're not going to hurt the patient as long as you're not incising into mucosal tissue.
Absolutely. So as far as the way you look at socket grafting, you showed a socket where you used an osteogen plug, and you showed a socket where you used particulate and a collagen membrane. How do you divide? Is it based on the number of remaining walls? How do you determine?
That's great. I wish we had more time today. Maybe we can do a part 2 of this, Neil, in the future. And we can demonstrate that. So my rule of thumb in my practice, if all the walls are intact, they're all intact, is a simple thing to use is an osteogen plug, in my opinion, because it's very inexpensive and it works great. And I can thread an implant directly in it. Okay, it's like caulking; it pushes into the walls.
So you're saying I've got the buccal wall, I've got mesial and distal walls, I've got the lingual wall.
I call it a 4-wall defect. It's all there.
Okay.
Now,
I think sometimes they call that a 5-wall because they count the apical.
Yeah, the floor. They call the floor. Whatever. Tomato. But if I lose a facial plate, which often happens, my rule of thumb is if that defect is 5 millimeters or more, I will always use an allograft material and a membrane placed at least 2 millimeters beyond the defect. If I have 10 millimeters of facial wall gone, I can still put an implant. I will use an allograft, but I have to put that membrane at least 10 millimeters into the site, which means you have to know how to reflect. That's my rule of thumb in my practice.
Okay, and we had a question about which membrane you use, and it kind of goes to the 3-4 month or the 6 or the 4-6 month. So when we, you were very instrumental in helping us design the Newport Biologics membranes, and that's what we call it. We simply call it a 4-6 membrane or a 3-4 membrane because that's how long it lasts.
Well, and again, in my practice, I use a 3-4. That's what I order mostly. We probably have a few boxes of the 4-6, but again, I just need it there for 6 weeks. So it's a phenomenal membrane, easy to manipulate, easy to use. I love it. There's no reason for me to use anything else because I get tremendous results.
And these are the Newport Biologics membranes.
Newport, always
from,
Newport
yeah.
Biologics, yes.
Okay, great, great. A question about the number of times that you make a cone beam image. It seems excessive. Like how many times will you take a cone beam on a patient?
Great question. Well, again, we're educators, and I'm showing you that to educate, to demonstrate what we're doing. I will use my CBCT preoperatively, and oftentimes just to evaluate if it's a site that I want to do. Do I have adequate bone? Do I have to do something more invasive? It allows me the opportunity to sit with the patient and show them, not in technical terms, but in basic terms, why we need to do a sinus lift, why we need to build the bone, why we need to position it. I can actually virtually place my crown using my CBCT in the practice. So it's an education tool. I will oftentimes use my CBCT if it's a challenging, if I have anatomic concerns, very narrow areas, the premaxilla or the symphysis area, to make sure that I'm not improperly placing the implant. So I may take one mid-surgery to make sure that I'm in the right position. Oftentimes I will take one post-operatively if I feel the need for it. So one for sure, maybe up to 3, depending on how complicated the circumstances are.
Got it. And it's always the risk-reward ratio. Is it something important for the benefit of the patient? Then it's worth the yeah. Now, I've got a question here about a video of your suturing process. I know you've made a lot of good videos. Do we have any videos of your suturing process?
Yeah, in the very beginning, because I apologize for messing up here, but if the doctors go to drkosinski.com, drkosinski.com, my name.com, it is my education website. So there's probably 250 videos on there. They can go to Facebook, YouTube. They can go to YouTube. Don't go to Facebook. Go to YouTube, and there's just a myriad of all these procedures on YouTube.
And I might also add, our colleague, Dr. Taylor Manalili, she teaches an online hands-on course. Yes. So when you sign up for the course, we send you a little silicone model, some sutures, some fake grafting material, and you attend the course, and she takes you through the suturing process. So that's a good possibility also.
Great program,
but Dr. Kosinski's videos are awesome. Okay. Are you always removing the sutures 1 week from placement? What was the longest that you would leave them in?
It's not so much removing the sutures because they are resorbable. But I will tell the patients, I like to see them in a week because everybody heals differently. We have an older population. They're on a lot of medication. Everybody heals differently. I'd like to see the patients in a week. If I'm going to see the patients in a week, I might as well remove the sutures. I like to say a week to 10 days. The reason I do that is, and if you don't explain this to the patient, sometimes they'll call on day 4. They'll call the staff and they'll say, I was doing really great. I didn't have any problems. But today it's starting to hurt. So something's wrong. I think the implant's failing. And it's because the epithelium wants to heal and the sutures are preventing it. So if you explain it ahead of time, once you remove the sutures, they have release and the epithelium grows even quicker. So a week to 10 days, but we have a lot of patients in Michigan that go to Florida. I mean, they leave. So, hey, I just explained that situation. It's going to take up to 28 days for them to come out completely. But I like to see my patients in a week if possible.
Okay. And you already explained this, but just to answer a question up here, he's not using any membranes that need to be removed. All the membranes are collagen membranes that are resorbable, so you don't have to go in again.
Yes,
and
100% of the time.
Yep. Let's see. Fibro Guide. Are you familiar with that material, Fibro Guide to increase keratinized tissue?
No.
Okay. And do you ever put a suture into the membrane to hold it in place?
No. I want to passively place it. Again, very important. You have to reflect envelope. That membrane I have to see where the defect is. That membrane has to be passively placed at least 2 millimeters beyond the defect. I know as general dentists, we like to tuck and push and tear and rip. No, if you're going to do this, do it the right way. And it's passively placed onto the palatal lingual it doesn't go anywhere. The Newport biologic membrane adheres to it. I rarely use any pins or tacks, and I do not suture, because if you take this, your staffs can take the sutures out, they're going to pull the membrane out. They pull the membrane out before 6 weeks, the case becomes unpredictable. I don't know if it's going to work or not. And I don't want to have unpredictability for any of the people listening today.
Great, great. Here's a question about when you're using allograft particulate. Are you moistening it with saline, or do you use blood?
I'll use saline, I'll use sterile water, blood is fine, PRF, PRP, sticky bone, all depending on the situation. Most routinely, Neil, our cases, we do surgery every single day. And so I'm not going to draw blood on every patient just because we do so many. I will normally wet it with sterile water, sterile saline initially, and into a socket. The blood will adhere. A whole nother physiologic reaction there, but we just get great results in 3 to 4 months, and we can objectively determine that radiographically.
Great. Here's an interesting question. So when you're using the plug, the Osteogen plug, can you still bill that as a bone graft?
Yes. It's all
absolutely
the same. Bone
absolutely
graft
it is a bone. Yeah, it's
bone
kind of, I
graft
think you explained it to me once, that it's sort of like a graft material with a membrane all wrapped into one. It's
exactly.
I know that people have had tremendous success with that product. Yeah, I've got a question here. Can you just please post the exact type of plug, membrane, suture, and bone graft material we use from Newport Biologics? I have to be honest, we put together the Newport line with the advice of Dr. Kosinski. So there are not a whole bunch of different choices. There are really a small number of products that will treat about 90% of the situations that you're going to encounter. So, there's particulate. We do have the allograft in a syringe. Have you used that?
Yeah, I do. It's more expensive, and we all have our favorites. What I would suggest, Neil, is Glidewell Direct. All the reps there just say, "I want what Kosinski uses," and we've gone through and we've trained so many people. They'll give you the list of what I recommend at our courses. We have a big course coming up next week, I think, Neil. I don't know if it's sold out or not, but certainly I have my suggestions on what people can buy, and I know you guys have. You buy so many different units, you get something, a kit, a grafting kit or something like that. So if you talk to the great people at Glidewell Direct, they'll direct you.
Very good. Well, Tim, as always, it was a wonderful lecture. Your teaching style is just so helpful and just so straightforward. We really appreciate it. I think the difference is you are doing cases every single day. You do a ton of cases. You've always got new cases to show us, and it's just a very practical way of learning. So I always appreciate you coming. I know you're on the road in Manhattan right now, so we appreciate you doing this from your hotel room. Thank you very much. And thanks everybody for joining us today. Thanks to the panel. And be sure to join us next week when we'll have, as always, our business advisory panel. And our guest speaker will be Dr. Kevin Suzuki, continuing his discussion of current guidelines for diagnosis and treatment of periodontal disease. So we'll look forward to seeing you then. Tim, safe travels and have a wonderful holiday weekend.
Hey,
Take care, everybody.
congratulations again.